Now we're going to cover the topic of what pulmonary assessment is. Pulmonary evaluation. We focused on HRCT because honestly, due to time constraints, going into spirometry, which is more well known and widely used by everyone, both in the MIR exam and during medical school, didn't seem necessary to us. So moving on to HRCT, what things are we going to assess in an HRCT or in systemic sclerosis? Parenchyma, signs of pulmonary hypertension, and the esophagus within the parenchyma, mainly looking for NSIP, but also other findings that we'll go over. NSIP being the most common. Remember that NSIP, UIP, and all these patterns are not actually radiological patterns. They are histological patterns, histological alterations that correlate very well with radiological findings. And that's why we use them in daily practice interchangeably. But really, it's because radiologically, they correlate very well with pathological anatomy. To define how to read an HRCT, what's important is that this entire outer area, in theory, we shouldn't be able to see anything. Why? Because it's the area of the secondary pulmonary lobule. As if it were the functional unit of the lung that is not visible radiologically, which would be this entire outer area, right? So the first lesion is like in dermatology, elementary lesions. Illustrated video, this image is like glass. I like the phrase I heard at the ACR. It's like the windshield of a car in the morning. You can see through it. You can see the structures, the vessels. The bronchi are dilated, but you're seeing it as if it were, right? White and hazy. Bronchiectasis and traction. Bronchiectasis are this image of the dilated bronchus, which indicates fibrosis. It's the bronchus being pulled by pulmonary fibrosis. We can also find reticulation, which is all this pattern here, and blurred, as if they were lines we shouldn't be seeing because the secondary pulmonary lobule should be there. And finally, we can also have honeycombing patterns, which are these images of dilated spaces resembling a honeycomb. There's really no mystery to it. So UIP would be the combination of these findings, especially mainly the ground glass opacity, but also traction, bronchiectasis, reticulation, and there can be honeycombing, although honeycombing is more characteristic of UIP, which is more associated with rheumatoid type patterns. Also, a typical feature of NSIPE is subpleural sparing and predominantly peripheral involvement. So, as I was saying, you can see in this image here how the area that is in direct contact with the pleura is spared. Additionally, another characteristic feature of UIP patterns associated with autoimmune diseases is the four corners sign, which refers to involvement of the lower part of the upper lobes and the upper part of the lower lobes. Moving on to UIP, which is much less common in systemic sclerosis, but still needs to be considered. As I was saying, it is characterized by exuberant honeycombing and may also present with bronchiectasis, reticulation, and peripheral involvement. In addition, the epicobasal gradient is also a very characteristic feature. This image might not be the best to illustrate it, but basically it means that the lungs are healthy at the apices and the condition worsens as it moves toward the base. Other things to keep in mind in systemic sclerosis that aren't actually due to the autoimmune involvement itself are, for example, microaspirations, which, as you know, are very common in scleroderma due to esophageal involvement, which are these tree and bud pattern images. Tree and bud means small nodules with lines crossing between them, like branches. And this is typical of both microaspirations and infections. In addition to that, you can also see consolidation images in an infection and cavitated nodules, like in pneumonia. We can also observe airway abnormalities, since like any patients, they may have COPD, they may have emphysema in the form of bronchiectasis and dilation of the bronchus larger than the accompanying artery arch. Accompanying artery and emphysema. These images here. Moving on to the evaluation of pulmonary hypertension, there are three things to keep in mind. First of all, the pulmonary artery being larger than the aorta, keeping in mind that in older individuals, there may be aortic dilation due to age, not necessarily an aneurysm. And therefore, this rule might not apply, right? The same goes for measuring the pulmonary artery. After all of these are indirect signs. So in older people, you might need to take it with a grain of salt, but another less well-known characteristic is the presence of arteries with a larger diameter than the accompanying bronchus in 3 out of 5 pulmonary segments. As I said, all of these are indirect signs, but they can certainly guide us, especially in systemic sclerosis. And then, at the level of the esophagus, mainly the contents in the esophagus, which is all this image here, that is not an air fluid level. In theory, there should be neither dilation nor contents in the esophagus, which ultimately should be functioning properly. So it's true that when radiologists see esophageal content in combination with an atonia or involvement, meaning a lot of ground glass opacity, it strongly suggests that it could be scleroderma, but also possibly another connective tissue disease.